All right, we're talking vents, and now let's talk alarms because your ventilator, it's gonna alarm a lot going down the road. So let's go over some common alarms that you'll see on your vent. This may be a big deal, may not be a big deal. We'll go over some common causes of these kind of one by one. A big deal one is an apnea alarm, so your patient is no longer breathing, and you're thinking, well, they're on a vent, so how can they? Well, why would that be an alarm? Well, maybe they're in a non-invasive mode. They're in CPAP, they're in BiPAP. Um, so if they're in one of those modes, you get an apnea alarm. That's one of those alarms to pay attention to. Reassess your patient, make sure the seal is good, and kind of go about your day, right? Then we've got airway pressure alarms, both high pressure alarms and low pressure alarms. So your high pressure alarms will hit here in the next slide or two with your high pressure alarms. Your low airway pressure alarms, you know what, 99% of the time, what that means is there's a leak somewhere. Your vent circuit, so that vent tubing going from your patient to the vent, something's come undone. Maybe it's come undone from the ET tube. Maybe it's come undone a little bit from the vent. So just check your vent circuit. Check that vent tubing. Make sure that everything is in place and has a good seal. That's usually what your low airway pressure alarms are. Your low minute volume alarms. Definitely pay attention to these. When you're in assist control, when you're in a pressure control situation, you might need to up your pressure. If you are in SIMV, make sure that your patient is getting all the breaths that they need. With your high airway pressure alarms, your high pressure alarms, um, so this is your vent telling you that it's taking a lot more pressure than it should to push in a breath. So we're going to be evaluating our patient first, but most of the time there's maybe a tubing kink. There's a kink in the vent circuit, in the vent tubing itself. Sometimes your patient just coughs during during a breath. It's going to cause a lot of back pressure and cause the alarm to go off. Lots of secretions, we can deep suction those out pretty easily. Any bronchospasms, any airway resistance issues is going to cause high airway pressures. Remember that. And then we get into like pneumothoraces, pulmonary edema. Those are going to cause high pressure alarms as well. And we just need to adjust our alarm settings is all we're going to do there. Might not be fixing a pneumothorax there on the side of the road, so we can just adjust our settings. We know it's going to take a little bit of a higher pressure to get a breath in, so we can just adjust our alarm settings there. Sedation-wise, pay attention to this one and pay attention to your vital signs. If you've got a sedated patient, if you've got a paralyzed patient, once the sedation starts wearing off, they're still paralyzed, but the sedation is wearing off. This is one of those signs that you need to resedate your patient. So with these alarms, a fun mnemonic for you is dope. So we've got these alarms going off, and we're going to think dope first. So first thing we're going to think about is tube displacement, because that's the most deadly, right? That's the most severe, most serious thing that could happen. We're going to double check ET tube placement. Now we're going to listen to lung sounds. We're going to listen to epigastric sounds. We're going to double check that the tube is still at a depth that we marked it at before. Say it's 22 centimeters at the teeth, or not centimeters, 22 at the teeth. Um, so make sure it's where it should be. Then we're going to check for obstructions, right? We talked about those, or mentioned those secretions. Maybe there's an obstruction in the tube. We can suction out. We can deep suction that obstruction out. Think about pneumothorax. Maybe we know that beforehand. Maybe we can assess for it now. Maybe they didn't have a pneumothorax, but during our displacement check, we don't have lung sounds on one side or the other, and the tube is still in a normal spot, so we know it's not too deep. Well, maybe they've developed a pneumothorax. And then our last one, so these kind of go in order of significance and of severity. Last one is just equipment failure, right? So something's gone wrong. We're not ventilating our patient properly. Well, our last check is going to be our equipment check. So is our equipment functioning properly? All right, so we've fixed our alarms and we're taking care of our alarms, but now we've gotten an ABG back that's just kind of weird and odd. Or maybe we're taking off with a patient, transporting a patient now. We've got the last set of ABGs, and we want to kind of fix and change our ABG values. So in this first case, we've got an issue with oxygen. I want to change my PO2. Let's say we've just got them on SpO2. I want to change my patient's oxygen status. Well, there are two settings we can play with. One is FiO2, the fraction of inspired oxygen, and the other is PEEP. So if I play with my FiO2, I'm going to increase it, let's say from 21% to 30%. Well, then that's going to increase the oxygenation of my patient, isn't it? If I just give more oxygen, it's pretty straightforward. If I increase PEEP, that's also going to increase oxygenation. It's going to increase my SpO2, my PO2. So if I increase PEEP from 3 to 5, we're going to increase oxygenation. We're going to recruit more alveoli to get oxygen swip-swapped with carbon dioxides on my hemoglobins. On the other hand, maybe I have an issue with carbon dioxide. I want to change my carbon dioxide level, so my PCO2, or I'm measuring EtCO2 and tidal CO2, and I want to change that. Well, instead of playing with FiO2 and PEEP, that's not going to do anything for carbon dioxide. Here I'm changing with my tidal volume and my tidal rate. So it's all about minute volume here with carbon dioxide, how much carbon dioxide I am breathing off. So if I want to lower my carbon dioxide, I can increase my rate, or I can increase my volume, my tidal volume. If I want to raise my carbon dioxide levels, I can do the opposite. I can lower rate, or I can lower my tidal volumes. Usually, volumes typically the first you're going to go to. If you have just a normal rate, let's say we've got a rate of 12 and their carbon dioxide's a little bit off, we'll hit volume a little bit. So just a point that FiO2 and PEEP change oxygen levels, tidal volume and rate change carbon dioxide levels. So if you're just out there in the field and you've got a patient being ventilated via BVM, let's say a firefighter is ventilating via BVM, you've got a low SpO2, and your firefighter starts bagging faster and faster and faster and faster. That's not going to do anything for oxygenation, right? Because volume and rate control carbon dioxide levels, not oxygenation levels. So remember volume and rate for carbon dioxide, FiO2 and PEEP for oxygen levels. Oh boy, so now we've got all of these options, we've got all of these settings, we've got all of these modes, we've got all of these alarms and all of these options going on. I've got this patient to transport. So what settings do I pick? Well, you go into the hospital. What are the hospital settings? Talk to the respiratory therapist. Talk to that patient's respiratory therapist. What are the settings there? Are they working for that patient there? They probably are. They've probably dialed it in for that patient. So you know what? We're gonna go with those. Those are going to be our initial settings. They're going to be our hospital settings. This is not an emergency patient, right? They might tone you out for an emergency transport, emergency transfer, right? But is this really a time-sensitive emergency? Probably not. So flip them over to your event, change them over to your event. Let them acclimate to your event. It's a different machine. You're not going to be using the hospital's kind of standalone event that your patient has become acclimated to. So give them some time. Give them a few minutes. Give them 10, 15, 20 minutes to acclimate to your event before you go anywhere, because they might need some adjustment, and you want to adjust that before leaving because you've got a respiratory therapist right there. You've got a physician right there. You've got maybe an ICU nurse right there who can help you out a lot. You've got a lot of resources right there next to you. So when choosing what to start your patient on, if you're taking them from the hospital on an interfacility transport, just copy what the hospital's doing. Give them a few minutes to acclimate to your event, to your machine, and then if something is going a little wonky, adjust it and use the resources you have there with you. Whew, but what if it's your choice? It's not an interfacility transport. You don't have a respiratory therapist right there. You just are beside this patient and you're putting them on a vent. What do you choose? Like I said, I'm just going to go with SIMV, just in case the patient starts breathing on their own. If they're not breathing on their own, SAMV acts a lot like assist control with some extra boundaries and extra stuff kind of thrown in. You can use SIMV. That's my go-to. You can use assist control. So if you're using assist control, just know that your patient is going to have to be fully paralyzed, fully sedated for it to really do its thing. So SIMV or assist control, if you have your own patient, you just RSI'd them and you're doing your own thing without the aid of any extra resources or respiratory therapists. If you have any questions, comments, concerns, or cuss words, please let me know.